Hello, everyone. Thank you so much for joining us today for our Health Professions Educator Health System Science Open Forum session. We have Dr. Sarah DeWitt presenting for us today and are super excited to hear what she has to bring forward for us. Dr. DeWitt is a physician in palliative care and emergency medicine with Carilion Clinic. She's also the program director for hospice and palliative medicine fellowship and is an assistant professor in the departments of internal medicine, health systems and implementation science, and emergency medicine, as well as the elective director for palliative medicine. Just want to note to you, please feel free to add any questions that you may have in the chat, and we will be checking for those throughout. Dr. DeWitt, I'm going to go ahead and turn this over to you.
Thank you, Sarah. Welcome, everybody. Thank you for joining us. Hope everyone was able to log in okay. We were all kind of having some login issues with Zoom today. A special shout out to Dr. Ohlendorf, who gave me the idea of the title for this talk. I really appreciate that. I was having a hard time figuring out a title. So living ethics, because this is something that we live with every day and deal with every day, as we'll kind of talk through a little bit more today. At any time, if you guys have any questions or have anything you want to add, please don't hesitate to raise your hand or add something into the chat box. And I think that's going to be monitored as well. Okay, next slide, please. So our objectives for the day, we can't start an ethics discussion without at least reviewing the basics of ethics and describe the pillars of medical ethics. We're going to talk a lot about the impact of values, professional ethics, legal responsibilities on decision-making in healthcare systems. We're going to talk about the process of ethical decision-making in a clinical setting and really focus a lot of our time on identifying opportunities to incorporate education surrounding medical ethics in your clinical practice on a day-to-day level. Next slide, please. We also can't talk about health system science and ethics without bringing in our wonderful health system science wheel. So this is something that we all know and love. And I think in the red there, you can see that ethics and legal aspect of medicine play a huge role in health system science. And we're going to talk a lot today about how common ethical issues are really on a day-to-day basis for probably most practitioners, whether or not something you are consciously aware of. These are some issues that absolutely come up every day, definitely in my world, and I think a lot in medicine in general. Next slide, please. Oops, we have our polls. Are you guys we're gonna have some polling. If you guys can answer these, and then we'll kind of see where everyone stands. Give you guys a few more seconds to answer, and then Deb, whenever you're ready, you can pull up the results of those.
All right, let's end the poll and see what we have.
Okay, thank you. Okay, can everyone see the results of that? So I was curious, how often do you feel you encounter ethical issues in your clinical practice? 59% of people said some of the time, and 41% said daily. Medical students I interact with have a good understanding of ethical issues that arise in clinical practice. We're kind of split here, almost 50-50. 53% said no, and 47% said yes. And then residents and fellows I work with are able to recognize, analyze, and navigate ethical issues in clinical practice. I like to see that 100% of people said some of the time, so at least they're some of the time recognizing these ethical issues. My hope, after several years in residency and also in medical school, that these numbers will start to increase as well. Okay, next slide, please. So let's review briefly medical ethics and the principles of medical ethics. I feel we can't really have a discussion on how to teach medical ethics until we kind of just have a basic review of the medical ethical principles that we encounter every day. So the four main principles of medical ethics are autonomy, beneficence, non-maleficence, and justice. There's a school of thought that say there's six pillars. Some people say 4+2. Regardless of how we kind of categorize these other two, dignity is really important, and honesty or what's known as veracity is another element or another common principle of medical ethics that we should talk about. And we're going to briefly go through each of these individually. Next slide, please. So beneficence, this is the ordinary meaning of the principle that healthcare providers have a duty to be a benefit to the patient. So we need to act in the best interest of our patients, do good for our patients, and advocate for the good of our patients. Non-maleficence is that primum non nocere, that our duty to do no harm. I think it's important to note that really anything in medicine, whether it's just even a lab test or it's a medication or a major surgery, there's always going to be burdens of a treatment option. There's always going to be risks associated with treatment. There's always going to be side effects of medications or treatments that we offer. And we should really on a moment by moment and day by day basis be weighing the benefits of these treatments versus the harm that we know are inevitable in some things that we do. And so I think non-maleficence, we need to really focus on. Part of non-maleficence is really focusing on not offering care to patients that are really more harmful than beneficial. And that can get really hard, especially nearing the end of life. Part of non-maleficence is also this obligation to protect those patients who are at risk for abuse or neglect. Next slide, please. The right or the principle of autonomy. This is the right to self-determination. I get to decide what happens to me. I get to choose my medical care. And so the idea of this is nothing to, for, or concerning a person against their will. We're going to talk a little bit about the historical impact of several cases in the 70s and 80s and 90s that really impacted autonomy and really made it a main focus really of American medical system. We have a right to determine what happens to ourselves. Part of autonomy is also this idea of capacity versus competency. One's a medical term, capacity, one's a legal term, competency. It's important to also talk about substituted judgment and surrogate decision-making when patients lack competency or lack capacity. And then informed consent is a really important part of autonomy. We can't expect our patients to make decisions for their care or for their loved ones' care if they don't have all the information they need to make an informed decision. So informed consent is a topic that comes up when we start really talking about autonomy. Next slide, please. And then justice. Justice is a really important pillar of medical ethics. It really came up in the COVID pandemic. This is the idea of to do the most good for the greatest number of people, and that all individuals are entitled to comparable resources and benefits, including access to care, treatments, and protections. When we were worried about scarce resources, we were talking a lot about how do we allocate scarce resources? How do we determine who gets this precious resource, whether it's a ventilator or an ECMO, or the COVID vaccine when it first came out, and how are we prioritizing who got those first? So justice really came to the forefront in the medical ethics world and really the medical world during the COVID pandemic. So it's important to think about. Next slide, please. And then veracity and respect for dignity. So it goes without saying that we are obligated to uphold confidentiality for our patients. We are obligated and we should tell the truth to our patients. We should be honest in their prognosis and discussing treatment options and discussing what is likely to happen to them. We also have an obligation to not abandon our patients. And we'll talk a little bit about this in a little bit, where this really comes up. And obviously we should always respect our patients' emotions, their relationships, their reasonable goals, privacy, and bodily integrity. Next slide, please. I like this slide. I use this a lot in a lot of my educational endeavors regarding ethics, because it's really important to know that not one pillar or principle really outweighs the other. And in any given ethical situation, any given medical situation, there might not be one right answer. There might be multiple different options. And it's our job to, as providers, as clinicians, as educators, to really weigh, discuss, and balance the priority between these different principles that sometimes are in conflict with each other, right? Your patient who's becomes a protesting patient, who lacks capacity but clearly doesn't want this one thing to happen to them. What do we do with that? Sometimes, these principles aren't always in sync and they're not always on the same page. And sometimes, as I mentioned, there's not one great answer. Rather, there's a possibility of answers, and it's our job to find the best answer for our patient at that time. I'm going to briefly review, whenever I talk about ethics, whether it's to the medical students or to residents or fellows, I think it's important to review the AMA, American Medical Association Code of Ethics. And I'm going to briefly go through this. So if I talk really fast, it's just because I've given this a lot, and I've said these 9 principles or these 9 codes of ethics very frequently. But it's important to remember that we made an oath, and whether or not we agree with what the AMA says, I think these principles hold true. A physician shall be dedicated to providing competent medical care with compassion and respect. We shall uphold the standards of professionalism, be honest in all of our professional interactions, and strive to report physicians deficient in character or competence. We shall respect the law and also recognize a responsibility to seek changes to those requirements which are contrary to the best interest of the patient. We shall respect the rights of our patients, our colleagues, and other healthcare professionals, and shall always safeguard patient confidences and privacy within the constraints of the law, obviously. Next slide, please. We shall continue to study and advance scientific knowledge and maintain a commitment to medical education. We should be free to choose whom to serve, with whom to associate, and the environment in which we want to provide medical care or practice medical care. We shall recognize a responsibility to participate in activities that contribute to the betterment of our communities. And we shall, while caring for patients, regard responsibility of the patient as paramount. And we shall support access to medical care for all people. So a nice reminder of some of the things that we should be doing on a day-to-day basis. And I think all of us do strive to really follow these codes. There has been several landmark historical cases that really exemplify some issues in medical ethics and really, have led us to where we are today in terms of why we prioritize certain things over the others. And again, I'm going to just briefly talk through these because I don't want this to be the main topic of our conversation, but I think it's important to recognize that there have been several really important landmark cases that have guided us and have changed medical ethics and kind of changed how we treat patients and the recommendations that we make to them. So the first case, the first right to die case was Karen Quinlan. And I hope you guys have probably all heard of Karen Quinlan. In 1975, she was in a persistent vegetative state after a motor vehicle accident. Her parents, after a period of time, I think it was just several weeks, wished to allow her to die naturally. And the doctors refused, stating that removal of life-sustaining measures was the equivalent of murder. And so you have to think back. So 1975 was only 30, 40, 50 years ago, really not that long ago. Whereas in today's standards, we know that patients have a right to choose their medical care. Their surrogate decision makers have a right to withhold or withdraw life-sustaining treatments. But 50 years ago, this was considered murder. Then it went to the New Jersey Supreme Court, where the court found that families and surrogate decision makers could use quality of life as a legitimate factor in making decisions regarding the withholding or withdrawing of life-sustaining measures. Interestingly, she ended up surviving. So her parents wanted to take her off of life support, so ventilator. She ended up surviving about 10 years off of mechanical ventilation, but she did receive artificial nutrition and hydration. Next slide, please. So in 1983, this was the first case. Nancy Cruising case was the first case to get all the way up to the Supreme Court. And she was in a persistent vegetative state. Oh, I'm sorry, she was the one that was thrown from her vehicle. Quinlan was the one that was at a party and became unresponsive. Nancy Cruising was thrown from her vehicle, and she received resuscitation, and she was in a persistent vegetative state that required artificial nutrition via a PEG tube. After several years, her parents requested that her feeding tube be removed, and the hospital refused. This went all the way to the Supreme Court, and where they found that we have a fundamental natural right to refuse or direct the withholding or withdrawing of artificial life prolonging procedures when a person has no more cognitive brain function and there is no real hope for further recovery. And then not even 10 years later, I think we've all heard of the Terry Schiavo case in the 90s. This was a really prolonged case for several reasons. Terry Schiavo suffered a cardiac arrest. There's likely thoughts that it was due to some complications from her bulimia, although there's some discussion regarding that. Her husband and her family sought treatment for her for 8 years. 8 years, they took her from place to place to try to get neurological improvement. After 8 years, it was found that she wasn't really improving at all, and she was in a vegetative state. Her husband requested that her G tube be removed because he did not feel she would want to be alive in the state that she was in. It took 2 years for the courts to agree, and another 5 years in which her parents appealed. But this was a case that really highlighted the different moral views of different religious communities, and just different ideas of thought regarding artificial nutrition and hydration. Ultimately, she was allowed to die peacefully. All right, I'm going to stop there for just a second and see if anybody has any questions so far. Okay. And again, please feel free to interrupt me at any time if anybody has any question. We're small enough.
Sarah, I was thinking, when you gave the first two cases, I was thinking the pendulum has swung now, right? To where I think healthcare teams are trying to convince families to withdraw care in certain situations, as opposed to at least the first case. So do you see that a lot more, or was it just the cases that you provided happened to be?
Yeah, I think it's a combination. I think there are certain cases where providers are now recognizing when care is medically or ethically inappropriate. To continue really life-sustaining care would be maybe medically inappropriate. And they are pushing families when in that case to, making strong recommendations for the withholding and withdrawal of life-sustaining measures. I think that, there's a lot of fear of that. There's a lot of fear for providers to make those strong recommendations. There's a lot of fear for families to receive that information, because I don't know if there's a lot of trust. There's a breakdown of trust in the healthcare system, in the medical care system. And I think a lot of times when you hear of stories, whether it's in the media or personal stories from family or friends or acquaintances, they're saying, the providers are really pushing for us to stop care, to really stop life-sustaining care. There's usually like a negative connotation with that. And so, I don't know where the breakdown lies, but I think it's a combination of, hopefully it's medical providers making strong recommendations that are medically appropriate. So if it is medically appropriate to withhold or withdraw life-sustaining measures, hopefully they're making those recommendations. And hopefully there's enough trust on the family side to hear what those medical recommendations are.
It is incredibly tough,
Mm-hmm.
but I know there's a lot of backing behind the decisions that are made. There's a couple of questions in the chat, if you want to take a minute to answer them.
Yeah, let me find the chat. Sorry. Got it.
Okay.
All right, Dr. Ollendorf, I would like your opinion on how OBGYN meets the AMA Code of Ethics and respects the law that affects access to reproductive health care for their patients and can cause them harm. That's a great question. And one I have not read exactly the AMA's opinion. So the AMA publishes their official opinions, and they have a whole list of them in regards to a number of ethical issues. I will, after this, if anybody's interested to Google it, they can try to find if there is a formal opinion by the AMA. I do know the AMA has historically been very conservative. And so hot topics, particularly regarding reproductive health or transgender care, might not be given an opinion. In fact, the AMA only recently came out with an opinion within the last 4 years regarding physician aid in dying. Before 4 years ago, their opinion was that it was morally unacceptable. And now they have a stance of neutrality. So the AMA is always a little bit delayed in when they come out with their recommendations or their opinions. And Dr. Schlupner wrote, where's the AMA in terms of patient advocacy today? It's a good question. I think they have their own priorities, and depending on, the topic at hand, I think, love them or hate them, they're an organization that are probably funded by just like, politicians. And there are certain things that are probably more important to them than others. Like I said, though, they've been a little bit delayed, especially in some of the big social issues of the day. I know physician aid in dying well, just because that's something, that's relevant to my clinical practice. So I can really speak on that, but the other two, I can't really speak on fully what their opinion stance is on that. All right, so let's talk about why ethics is really important in clinical practice today. In order for it to be important to teach our medical students, our residents, and our fellows, I think we all have to recognize that it's important in everyday clinical practice. And I would argue that, I know most people said that they sometimes deal with ethical issues. I'd argue that we probably deal with it on a day-to-day basis. We probably just don't recognize it for what it is. Next slide, please. Here's a list of some likely scenarios that come up, that could come up on a day-to-day basis, right? What if a patient refuses treatment, any treatment, simple as antibiotics, or they refuse your recommendation to change lifestyle, or they refuse to stop smoking, or they refuse life-sustaining measures? What if a healthcare decision goes against a patient's cultural belief? What if a member of the healthcare team makes a life-threatening mistake? What if a healthcare decision goes against your own, as a physician, your own cultural beliefs? What if your minor patient is diagnosed with pregnancy or STI? So I think, and these are just some really brief examples, but I think it's important to think there are ethical questions that arise probably every day, all the way from OBGYN to medicine to peds. And from a workplace, even if you're not seeing patients clinically, from a workplace, there's institutional ethics. There's lots of ethical issues that arise just from an institutional perspective as well. Next slide, please. So since ancient Greece and the Hippocratic Oath was created, physicians have been held accountable for taking care of their patients and ensuring little or no harm to them comes. The concept of a code of ethics that lays out guidelines for physicians' professional conduct and their ethical obligations has remained relevant in the healthcare field ever since. The rapid development of medical techniques, treatments, and knowledge following World War II culminated in the creation of several core ethical principles that are still used today in medical field to guide ethical decision-making and patient care. And those are the ones we really reviewed earlier. Next slide, please. Oops, one back. Healthcare professionals honestly face ethical dilemmas every day. With advances in medical technology and increasingly diverse patient populations, the industry's need for clear ethical guidelines is more critical than ever. These ethical issues in healthcare can be challenging, and for a lot of people, whether it's from your nurse or your support staff, or even you as a physician, this can lead to moral distress, right? Doing something to people that is against our ethical standards or our own moral standards can lead to really moral distress. Healthcare providers prioritize patient well-being, which can sometimes mean respecting patients' wishes that they may disagree with. So we're not always going to agree with the decisions our patients or their surrogates make. Next slide, please. So for our patients, all the ethical principles benefit patients because it guarantees respect for patient autonomy and equitable treatment. And it guarantees that patients will receive the best care available based on their beliefs and their decisions. It also builds trust and allows patients to trust their healthcare practitioners without reservation. And this can be really important, especially when you're talking about really, when we're at a crossroads, when treatment or no treatment will make a huge difference in someone's health and well-being. Next slide, please. For practitioners, we know that there are situations where we might run into ethical disagreements with our patients, with families, with caregivers, with even other staff members, other practitioners, and with an ethical guideline, we can recommend a solution that places patients' care first. Having guidelines also to support one's decision allows for one's conscience to remain clear, and ethics will help dictate what the best decision should be for the ideal outcome. Knowing that there might not always be the most perfect answer, there usually is a combination of right answers. By having an ethical framework that encompasses the entire facility, healthcare workers can feel assured that their coworkers are operating at the same intent as they are, and it allows for easier communication between workers, fewer misunderstandings, and a greater sense of mutual trust. Ethical guidelines can help practitioners find the least obtrusive and most beneficial solution to a patient's issues available, reducing the chance of risky or unnecessary procedures and treatments. And the idea of non-maleficence extends to patients and colleagues in the healthcare field, right? Healthcare professionals can feel their workplace is safe, and administration can work to mitigate and alleviate stress as much as possible. So some things to think about, and kind of to summarize, ethics in healthcare is what guides the work of professionals in the healthcare industry. These considerations are an essential component of providing healthcare, and as they help ensure practitioners treat their patients with dignity and respect, and that decisions are made by healthcare professionals are fair and just. And ethics can help promote trust and confidence in the healthcare system. Slide, please. So 2 things to just think about. These are some kind of big ethical issues that I get questioned a lot about, especially with learners. So what happens when the legal system is at odds with medical ethics, right? This is a big one in our society today. And I quote the AMA just because they are, just easy to quote, and they have a whole thing on medical ethics. And I do believe in what they say here. A physician shall respect the law and also recognize the responsibility to seek changes to those requirements which are contrary to the best interest of the patient. I think we need to remember that we have an ethical obligation to fight some of these things that that ethically and medically are not appropriate, especially in different states and things you are seeing every day. I think Dr. Ohlendorf made a mention of that. Second thing is, next slide, please. What happens when our own personal beliefs get in the way of patient care? This is something to really think about. I think it's important because we all have to recognize that we have our own biases. We have our own beliefs and our own moral values. And we need to recognize that we have a duty to our patients, and that duty should come first. We might not always agree with the decisions our patients make. We might not always agree with what they want for their care. But we have a duty to help them. We have a duty to respect their decisions, and we have a duty to not abandon them in their time of need. So the AMA gave an opinion piece at this, and I just want to briefly read this. Preserving opportunity for physicians to act or to refrain from acting in accordance with the dictates of their own conscience is important for preserving the integrity of medical profession as well as the integrity of the individual physician. However, physicians' freedom to act according to their own conscience is not unlimited. They are expected to provide care in emergencies, honor patients' informed decisions, to refuse life-sustaining treatment, and respect basic civil liberties and not discriminate against patients on the basis of arbitrary characteristics. Next slide, please. So let's get to kind of the meat of the discussion. I know that was a big overview and a big talk about medical ethics in general. As you can tell, I can probably talk about this for a long time. I kind of want to talk next about why it's important in medical education and how can we best deliver this information to medical students, all of our residents, all of our fellows, every learner that we have come through. Because this should not just be left up to, medical school to teach them the basics of ethics. And this is something that we need to constantly continue to build upon on every level of education in the medical continuum. Next slide, please. So from a requirement perspective, there are requirements from the LCME and the ACGME that learners at all levels receive instructions addressing professional formation to prepare them for a lifelong commitment to professionalism in patient care, education, and research. This is ethics. A physician's ability and willingness to act in accordance with accepted moral norms and values is one key component of professional behavior. And there are educational objectives relating to ethics that are now often incorporated into broader goals for professional education. Next slide, please. So the LCME that kind of governs all undergraduate medical education, they specify that students' behavior must be observed and assessed to ensure that it is in line with acceptable ethical guidelines. It's kind of vague, and I know they're moving a lot more towards milestones and EPOs, but they are they are expected to receive education on ethics and to be measured and observed and assessed on that. The ACGME feels that it's so important that it's one of the 6 core competencies for all ACGME. Specifically focusing on professionalism, stating residents must demonstrate a commitment to carrying out professional responsibilities and an adherence to ethical principles. They're expected to show compassion and respect for others, put patients' needs above their own, respect patients' autonomy, act accountably, and demonstrate sensitivity to patients from diverse backgrounds. Next slide, please. So we know that it's important to teach ethics. Now, how do we best deliver this content to our students? Next, if you can just click it. We do this by cultivating behaviors that exemplify ethical and professional virtues. So in 2015, Academic Medicine actually published what's called the Romanell report. And it's probably, it's one of the first of its kind. It's a really well done report that it's an analysis of the current state of medical ethics education in the United States, both at the undergraduate and the graduate medical education level. And it proposed educational objectives that all medical students and residents should receive during their training. So upon completion of medical school or residency training, everyone should have an appropriate level of proficiency to demonstrate an understanding of the concept of the physician as a fiduciary and the historical development of medicine as a profession, recognize ethical issues that may arise in the course of patient care, utilize relevant ethics statements from professional associations to guide clinical ethics judgment and decision-making. So think the Choosing Wisely campaigns. Think critically and systemically through ethical problems using bioethical principles and other tools of ethical analysis. Provide a reasoned account of professionally responsible management of ethical problems and act in accordance with those judgments, and articulate ethical reasoning to others coherently and respectfully. We expect our learners to come out doing this, and I think we behoove it upon ourselves to maybe recognize that maybe we all don't do this as well as we should. And so we might need to be better role models on a day-to-day basis. Next slide, please. And I'll let you guys kind of review this because it's very wordy. But the report also kind of, in particular, delved into some specifics that they expect learners to be able to objectively do at the end of their education, including like confidentiality, right? Shared decision-making between your patient and yourself, dealing with conflicts of interest, researching the limits of research and using humans in subjects in research, managing challenging patients and families, the use of social media, religious and spirituality differences, all the way, and they talk about gifts. So it's a really good read. I recommend you guys review that. Next slide, please. So then how do we teach medical ethics and incorporate into the curriculum? It should be intentional, and it should include medical ethics at all levels of training. Next slide, please. It's important to remember there's no single best approach for teaching medical ethics and professionalism. The layered approach is best. So multiple times, discussing it. Also important to recognize, and this is true for any curriculum that you develop, learning styles and learning levels vary. And it's important to target, to deliver, know what you're delivering and to target that based on the learner level that you are targeting that at. Teaching methods should also be varied and flexible. And remember, there's really no one size fits all in anything related to medical education. So I think the first step, next slide, please. We all need to recognize that ethical issues arise every day in the practice of medicine, despite your specialty, despite your practice location. There are a lot of ethical issues that arise in the outpatient setting that we didn't really hit upon, but that happen every day. And one of my colleagues, Dr. Wani, and I deliver an ethics didactics to the internal medicine third years every 6 weeks. And she, we can talk a lot about, the ethical issues that arise in any clinic setting. It doesn't even have to be internal medicine, but just recognizing that every day there are ethical issues that arise in clinical practice. That's the first step, and identifying those. Next slide, please. And then with using that, whenever learner you have with you, it's being intentional. It's being intentional and talking about, these issues that arise. Say you have a patient who, and I do this bedside teaching, case-based teaching every day. We have learners every day on our service. And obviously in palliative care, I do realize that we are probably deal with more ethical issues on a day-to-day basis than most people do, most other specialties. But we are very intentional in how we teach. We are very intentional in how we review a case. And so a lot of times it's as simple as, who is the surrogate decision maker, right? And that goes back to your principle of autonomy. So it's tying in your clinical, whatever clinical problem you have, and tying it into some of these ethical principles. And that's probably usually actually easier to do than you think it is. So again, you go back to a patient who lacks capacity, right? Then you have to talk about, well, who should be their decision maker? Sometimes the person who legally is their decision maker might not always be the person who should be making decisions. But as with anything with ethics, we have to balance that with the legal aspects of medicine as well. And every state is different in regards to this. So oftentimes we have a case that we're talking about surrogate decision making and having to identify a decision maker. That's an ethical issue. Sometimes that person who lacks capacity is refusing care. And it could be for one reason or another, patient refusing an amputation, but clearly doesn't have capacity to truly understand that. They become a protesting patient. How do we balance that patient's right to not chop off their extremity, with maybe their surrogate decision maker's desire for their life to be prolonged no matter what? And so these are ethical issues that actually come up on a day-to-day basis. You have to kind of delve into, what's important to that patient, who knows them best. And sometimes you have to even get ethics involved. So bedside teaching is a really important way of delivering ethics education. In the clinic setting, you have a patient who's non-compliant. I hate that word, but they're labeled as non-compliant. They don't follow any of your recommendations. They stop coming to appointments. And they get to the point where, they keep coming in and asking for things that are unreasonable. How do you deal with a patient like that? That becomes an ethical issue, right? That's institutional ethics that comes into play. What are your policies at work? You still have a duty to help your patient and to make strong recommendations. You still have your duty to treat them with respect and dignity, regardless of the decisions they're making for their care. Or you have a patient who becomes combative and they have capacity, but they become threatening in some way or shape or form. Now, you have to balance your own safety with non-abandonment. Now, most institutions will support anybody if they feel threatened, that they are automatically allowed to fire a patient in that regard. But it's important to think about, because these might be things that come up both in the inpatient and the outpatient setting. And these are ethical issues that arise. There was a question in the chat. I'm going to try to find it, unless somebody can read it to me.
I can read it to you if you'd like.
Thank you.
Very practical question. From Dr. Hart, what is the current situation for obtaining an inpatient or outpatient ethics referral? Is there a referral mechanism that is easy to trigger in EPIC?
Not an EPIC, no. And they do that on purpose. But the way to do it is twofold. There is an ethics. There's always somebody on call for ethics, and you can use Perfect Serve for that. If you don't have Perfect Serve, then you just call the hospital operator and they'll get you in contact with whoever's holding the pager for ethics. But they purposely don't do a consult to ethics, because they need that conversation. The ethics, the people who do the ethics consults need to know, the situation. They need to have a discussion about it, because in order to give their ethical opinion, they need to kind of have, that one-on-one conversation.
Sarah, this is Michael Hart. I just wonder if that creates an artificial barrier, though. And perhaps a survey would be the answer to this, to find out how many clinical practitioners, if faced with an ethical question, know to go to the mechanism. Because I think that perhaps if there's a triggering mechanism in EPIC, it might be beneficial to open the doors for more potential referrals.
Yeah, that's a great question. Absolutely. I know that a lot of people come to the palliative care team to ask some ethical issues and help guide them some of the times, and sometimes we're able to help them with that. And sometimes we do also recommend a formal ethics evaluation or consult. I don't know if anybody is on the ethics committee that's on this call who can speak a little bit more to that practical nature of how to make that referral and how to make that phone call. But that could be a barrier. I do know for our residents and fellows, it's part of their orientation, how much they pay attention and listen to. I think they are given information on how to consult ethics if they have an ethical issue arise. But as far as, physicians in general, I don't know if it's part of any real orientation that we get when we, start working here. There was another question.
There is, Dean Lehrman types, thank you for this thoughtful presentation. What opportunities are there for health system science champions to point out how ethical principles are used in practice during medical student clerkships?
It's a great question. I know myself and Dr. Wani, we talk to the internal medicine clerkships about ethics, and we give, if you click the next slide, we give actually a formal didactic that's also case-based. And so we've created curriculum that's a combination of formal didactic / case-based / interactive to really talk about ethical issues that are arising in their clerkship years, in their clerkship days. Because what I found is that I can tell them cases, and a lot of my cases are actually very interesting, and it does get them motivated to participate and to listen, and to learn. I think learning best happens when it's really relevant to what they're doing. And so oftentimes I can pull from them cases that they're currently working on or working with, and patients that they're currently working with, and we can identify really cool ethical issues and then talk through that with the ethical framework. And so that's something that we do, part of health system science, but third year IM clerkship. Now, the other clinical champions kind of all have their own niche and interest in the health system science world. And I know that they all give didactics in all the different clerkships that are health system science related. Now, I would love to be able to give ethics lectures to every single specialty and didactic, but I do know that they all come to me at some point in their IM group. And then they also, another formal didactic that they get is in their first year, block 4, there's a whole block for ethics. It's an 8-week block that we really delve into the ethical principles. We delve in really as a case-based study, small groups, and it's facilitator led. Well, really student led, but facilitator helped. And we walk through really important cases, ethical cases in the topic at hand for that week. And so they get 8 weeks of ethics in their first year for block 4. Then they get a little bit of ethics when in their third year, system session. I give a system session for end of life care. And obviously you can't talk about end of life care without talking about ethical issues. And so we give another layered approach is we give there's a small group section of that system session where we talk about ethical issues that arise at the end of life. And then obviously in their IM third year clerkship. And my hope is that more and more students will do their rotation, one of their elective rotations in their 4th year with me, because again, we talk really about ethical issues on a day-to-day basis. And if they spend time with my fellowship, we have a 1-year fellowship for hospice and we give an ethics series. Really, Dr. Phyllis Whitehead really leads this, and she gives talks that are pretty advanced. We talk about medical aid in dying. We talk about our own biases and how it leads us to maybe make medical decisions. And we talk about there's some other big ones that I can't really remember at the moment.
Thanks.
I love.
Those are some really, sorry, Sherry, for interrupting.
No, you go right ahead.
I was going to say, those are some very robust opportunities you just described. And I remember teaching ethics cases in preclinical and clinical curriculum in a couple of other medical schools. And when you take it to that high standard and it's very deep and informative, sometimes that lets everyone else feel like they're off the hook. But the most powerful educational experience the students will have was when they bring ethical principles to the point of care from people who aren't necessarily experts, but can bring it to the point of care in a very convincing way with respect to, we need to do this right now for this patient, have shared decision making or to have autonomy or what have you. So looking at the world through ethics classes is something we'd like every clinical educator to have, so they can highlight these moments that occur in everyday practice. So that's why I start pondering what can we do on clerkships to kind of just weave it in. And those who want to go deeper certainly can and should, but to weave it into the everyday experience at the point of care.
Absolutely.
Go ahead,
Dr.
sorry.
Learman, yeah, that's my hope too, is that one, that we as clinicians and educators can recognize that there are ethical issues that arise every single day, probably for most of our patients. And then in us recognizing it, being able to verbally talk about it with our students on a moment to moment basis and bring it like into rounds. And it doesn't have to take long, and you don't have to be an expert in ethics to really recognize that there are ethical issues. And my hope is with that layered approach, we start really training up our medical students and really our residents and our fellows to recognize that, you know, they are an important part of the ethics wheelhouse, and that a lot of the decisions that they make and their patients and their families make are really housed in ethics.
And what a teachable opportunity when those everyday situations occurs, just to explicitly call it what it is. This is an ethical issue that we see every day, all of these things. And I love how Dr. Ollendorf mentioned he weaves it into his he weaves in ethics into the OB student lecture about abortion that he recently inherited. But there's so many things. We have these sessions all the time about the importance, all of these important things that the medical students and residents must learn about, but you can't just keep adding more things on and on without taking anything else away. So it's so important to just weave it into the teaching that and the learning that they get every day. Amanda Anderson also mentions that there are many applications for ethics and simulation sessions. So weaving that right in. They've done an EOL simulations with nurse residents where they are presented with some ethical considerations. I think that's a great opportunity. They're learning something else. The main topic may not be ethics, but there's ethical elements similar to what they encounter every day. Excellent. Thank you. Great points, folks.
Thank you, everyone. Absolutely. And I think that's my hope, is just that we all, recognize that these are issues that come up every day, that if we can recognize it, then we can teach our students this, or learners this, and we can kind of weave it into just a normal, our normal rounds. I know that we teach our students and our learners, how to manage X, Y, or Z. Who's to say we can't add, maybe once around or every other day, an ethical dilemma or an ethical issue as they arise. Just something to think about.
Sarah, this is Michael Hart. I one quick question. I put it in the chat box, but in full disclosure, I've retired from clinical medicine 4 years ago, but I just gave like pediatric grand rounds last month at Carilion. And as I was talking with some of my colleagues, it's interesting because I just had a very informal discussion with some of the senior practitioners and faculty there. And one thing that I thought was interesting, their frustration was, and this is where I came in the ethics realm, one of the topics that came up was over gender identity and transgender, and some of the things that were being, the students were, the faculty were frustrated by the fact that the students said, oh no, of course a 12-year-old should choose their sex. And they said that the students were very much, oh no, it's whatever the 12-year-old wants. We wouldn't let them get a tattoo or start smoking, or it's gone from mental health or, kind of a gender dysphoria to the frustration they had was that the medical students in the discussion group were completely in favor of the patient making the 12-year-old making their full decision. I don't have that much experience as a pediatric GI doc, but the transgender experience that I had when I took care of transgender, it was all, it primarily was single moms, and the investment to me in the three that I dealt with as patients of mine, the mother was much more invested in the gender change than the child was. And I thought, to the point where it was almost a Munchausen situation. And that's, you call it factitious. It's not Munchausen called anymore, but I mean, what I'm saying is that those are hot topics that I think the faculty expressed to me their frustration that they felt the students' perception was that they needed sort of a 30,000-foot view perspective on you're okay with the 12-year-old choosing, in fact, they're getting hormone therapy, and we're complicit if in fact this is really a deeper dive mental health issue. The students didn't feel they needed a psychological evaluation, and they said, oh no, they should be able to choose what gender they want without any sort of judgment. They viewed a psychology or psychiatry evaluation as being judgmental. And I thought, wow, that's interesting how that's almost a generational change.
That's exactly what I was going to say is I think that some of these, especially the hot topic issues that are generational, dependent on how, some different generations view, these ethical dilemmas.
Right.
I think that what we hope is, especially in their first year, because in their first year in their block 4, we do talk about transgender care as part of one of the cases in regards to, I think it's autonomy or beneficence or non-maleficence. I can't remember exactly which week we add that in. But, our hope is that they're not just a blanket, yes, this patient should just get X, Y, or Z because they want it. And my hope is that in talking about ethics and debating ethics, that they are really able to sit and come up with an ethical analysis surrounding that issue, because it's not black and white. Nothing really in medicine or life is black and white. And my hope is they're not reflexively just saying,
I think it's magnified in, I would say, pediatrics and obstetrics. And I'm sure that those two disciplines, whether Dr. Lehrman gets a 14-year-old who wants an abortion without parents' consent, those kinds of issues are really hot topic issues. That those two disciplines, not to say that medicine doesn't deal with those every single day, but those are really hot topic issues that I think having the access to your expertise in the evaluation might really help.
Absolutely. And if anybody ever identifies an issue that comes up in clinical practice when they're, in regards to education, and they're kind of stuck on how to educate this group of students on something, I'm happy to always field questions and answer things, especially from a non-clinical perspective. If it's a clinical question, obviously we have our wonderful ethics department and our clinical ethicists that can help with that. But I'm always happy to field any questions non-urgently about how do we teach our students how to think critically, how to do an ethical analysis based on the clinical situation at hand.
I agree. I think Dr. Ollendorf's comments that their ethical decisions in every decision you make is absolutely spot on. We may kind of be unaware of it, but it's just a degree of how significant they are or not.
No, and I say that as an obstetrician. I mean, everything we do in obstetrics is mom versus fetus. I mean, everything we do, and I do addiction. So the question is, what do I do? I'm giving a medication to a mother for her benefit, which may have an effect on the newborn.
Absolutely.
That's an ethical dilemma, right? Every procedure we do in obstetrics has that, and it gets complicated with the legal work. That doesn't help either.
Well, I'm sure, and there's a lot of situations where you may actually be forced, your hand may be forced because of legal issues, and I don't envy your situation, because if the mother's technically doing something harmful for her fetus, then I'm sure you must wrestle with these issues all the time of when do I pull the trigger and bring in law enforcement? It's got to be a tough day-to-day decision.
Called harm reduction. So we seek to find less harm. I mean, there's harm in lots of different things. Sure. But the law enforcement issue, that's a whole nother issue of the privacy of the relationship versus your duty to disclose, and that's a legal issue. Right. And I mean, it's there's so many things we could talk about, but Sarah, you can regain control of the conversation.
No, that's fine. I just think it's important, that whenever you talk about ethics, you do have to bring in the legal aspect of medicine as well, because so many of the decisions that we make, sometimes, unfortunately, or fortunately, depending on the situation, we're bound by the law in a lot of ways. And so they're not independent of each other. They're definitely,
Can I just add a very quick comment, Sarah? This is a good interchange that we've just had. And I would just point out that students are bringing to medical school the sensibilities of their generation, which has been pointed out, and they very much need an ethical way, the ethical principles as a way to understand how does this apply to the care of patients. They desperately need this in a whole lot of different issues that have become popular to discuss in society. The level of discourse in those discussions is minimal. It's not very rigorous. It's not very academic. It's more related to what identity do you want to have in terms of what side are you on in a given debate in our polarizing climate. So we've got to bring students back from that societal challenge that they have into the big middle that ethics provides. Because as I remember from my first philosophy course in college, I got it. They're really asking me to answer the question with another question. Okay, I understand that now. So ethics means a way of asking the right questions to get to a better understanding of how you apply the principles. And our students need this more than ever to change their thinking from student head to doctor head. It's really important.
My hope is with multi-layered approach, and getting them in their first year, following up hopefully in their second year, hitting it again hard in their clinical years. And then obviously we need to take it further and talk about, graduate medical education, the ACGME, and really hoping that every residency and fellowship really continues to reinforce these principles and this way of thinking. Hopefully it continues to grow their minds and how they discuss, debate, and consider these ethical issues. Absolutely.
Superb conference. Thank you. Really terrific.
Thank you. Next slide, please. So quickly, just some lessons learned in the last few years of me putting together multiple different types of curriculum together regarding ethics. No one size fits all. We have to tailor it to each training level. What I do for my fellows is vastly different from what I do for medical students, is even moderately different from what I do for residents. Be varied in your approach to education, especially with regards to ethics, right? We can't just do, a case-based learning. We do have to talk about the principles. We have to talk about how to do an ethical analysis. Then we have to layer it with case-based and what's relevant to them at the time. As I mentioned, learners of all levels like real life cases to discuss. Multi-layered approach is best. And if you get feedback on a session you give, take it seriously, but be cautious to change your curriculum based on a single data point. And that's it.
Very nice, Sarah. Very nice.
Thanks for the discussion, everybody. And as always, if you guys have any questions or feedback, please feel free to email me or give me a call.